Welcome, everyone. Today, we are diving deep into a huge topic in internal medicine, cirrhosis. We're going to go from the microscopic changes that actually define the disease all the way to the big macroscopic consequences we see in our patients. The goal here is to build a really clear framework so you can understand this super complex condition. All right, let's get started.
So picture this. A patient walks in with a swollen belly from ascites, yellow skin from jaundice, and they're confused. This classic triad, it's not just a sign of some liver problem. No, this is decompensated cirrhosis. This patient has really crossed a critical line. We're way past just dealing with some abnormal liver function tests. What we're witnessing here is straight-up end organ failure. This scenario, it just perfectly captures the seriousness of what we're about to unpack.
So what exactly is cirrhosis when you look at it under a microscope? Getting this pathological definition right is absolutely essential because it defines the point of no return. It's an irreversible state that dictates pretty much everything: the prognosis, the management, you name it. Okay, this definition highlights the two features that are the dead giveaways for cirrhosis. First, you've got fibrosis, which is basically scarring, and second, the formation of these regenerative nodules. It's this exact combination, these bands of scar tissue trapping pockets of regenerating liver cells, that just completely distorts the liver's architecture. It messes up blood flow and crushes its ability to function. So remember these two terms. They are clutch for your exams: fibrosis and nodules. That is the histological signature of cirrhosis. So how does a perfectly healthy liver get to this end stage? Well, it's a long story of chronic injury and this sort of haywire wound healing response that just goes on for years and years. The whole process kicks off with some kind of persistent insult. Maybe it's alcohol, maybe a virus like hepatitis, or increasingly non-alcoholic steatohepatitis, or NASH. This constant injury activates a key player, the hepatic stellate cell. Now, these cells are usually just chillin'. But when they get activated, they transform and start pumping out way too much collagen. This collagen gets laid down as fibrous tissue, which starts walling off parts of the liver, creating those nodules and twisting the whole architecture. The activation of that stellate cell, that's the engine driving this whole disastrous process. And what's the end result of all this scarring and architectural chaos? Well, it all boils down to two massive systemic problems. First, all that scar tissue makes it harder for blood to flow through the liver. This causes pressure to back up in the portal vein, and that's what we call portal hypertension. Second, the liver cells that are left just can't keep up with their jobs, their synthetic and metabolic duties, which leads to liver failure. Literally every single clinical sign of cirrhosis comes from one or both of these two things. And this dual framework, thinking in terms of portal hypertension and liver failure, is absolutely the key. It's how you organize and really make sense of the huge range of symptoms a patient with cirrhosis can have. Now check out this breakdown. It makes so much sense. On one side, you have the signs of liver cell failure. The liver can't process bilirubin, so the patient gets jaundiced. It can't make clotting factors, so you get coagulopathy and they bleed easily. It can't produce albumin, which leads to fluid shifts and edema. Then, on the other side, you've got portal hypertension. That high pressure forces fluid out into the abdomen, causing ascites. It pushes blood into smaller veins in the esophagus, creating these dangerous varices. And it backs up blood into the spleen, causing it to get huge. You see how it all connects back? We also see these really classic physical exam findings that are all about hormonal imbalance. A failing liver just can't metabolize estrogen effectively. So you get this state of hyperestrogenism, which causes blood vessels to dilate. This leads to those little spider angiomas on the skin and palmar erythema, that classic redness on the palms. Okay, so once you suspect cirrhosis, what's next? You have to confirm the diagnosis and, just as importantly, you have to stage how bad it is. And that's where our investigations come in. The workup always starts with blood tests. We look at liver function tests or LFTs to check for liver cell injury. But honestly, the most important lab marker here is the INR. Why? Because the liver makes most of your clotting factors. So the INR gives you a direct, real-time look at how well the liver's synthetic function is working. An abdominal ultrasound can show us that classic nodular liver surface, and an upper endoscopy is crucial to screen for esophageal varices, which, as we know, are a major life-threatening complication. Now, to really quantify how severe the disease is and get an idea of the prognosis, we use clinical scoring systems. The classic one, and one you absolutely have to know for any exam, is the Child-Pugh score. The Child-Pugh score is brilliant because it mixes 5 key parameters: 3 lab values, bilirubin, albumin, and INR, and 2 clinical findings, how bad the ascites is and the grade of hepatic encephalopathy. The total score classifies cirrhosis into Class A, which is well compensated, Class B, or Class C, which is decompensated. And this score correlates really strongly with 1- and 2-year survival rates. It's worth mentioning, though, that the MELD score, which only uses lab values, is now more commonly used for prioritizing patients for liver transplants. Now, since that underlying fibrosis is irreversible, management really boils down to 2 main goals. First, treat whatever is causing the liver disease to try and stop it from getting worse. And second, manage the life-threatening complications that come with it. So let's quickly review the management for the big 3 complications. For ascites, the cornerstone is salt restriction and diuretics, mainly spironolactone, which is a classic exam answer. For those esophageal varices, we use beta blockers to lower the portal pressure and prevent a bleed. And if they're bleeding, we go in with an endoscope to ban them. And for hepatic encephalopathy, which is all about ammonia buildup, we use lactulose to help trap and get rid of that ammonia in the gut. This is a point that I really can't stress enough. That scarred, inflamed environment of a cirrhotic liver, it's basically a perfect breeding ground for cancer. So every single patient with cirrhosis has to be screened regularly, usually with an ultrasound, to try and catch hepatocellular carcinoma early, back when it might actually be treatable. So while we can manage all these complications, we can't actually cure the disease itself. The only definitive curative therapy for end-stage liver disease is a liver transplant. That's the only way to replace that scarred, failing organ with a new, healthy one. All right, let's do a super quick recap. The essentials. Cirrhosis is fibrosis plus nodules. This creates 2 huge problems: portal hypertension and liver failure. These lead to the big 3 complications: ascites, varices, and encephalopathy. And our treatment goal? Manage those complications, and when the time is right, consider the patient for a transplant.
And that brings us to one last, really crucial thought. You know, for decades, alcohol and viral hepatitis were the main causes of cirrhosis. But with the global explosion of obesity and metabolic syndrome, non-alcoholic steatohepatitis, or NASH, is on track to become the #1 reason people need a liver transplant. This is a massive public health challenge. Are we actually witnessing the rise of a new, silent epidemic of liver failure? It's a critical question for all of us at healthcare to think about. Thanks so much for joining this explainer.